First, let me give you some feedback about Sonoscanner, the company hosting this webinar. So we are Sonoscanner, ultrasound company, leader in clinical ultrasound. We're based in Paris, France. All our products are made in France. We are specialized in portable and ultra-portable system with very unique features, very unique probes, devices, and we differentiate ourselves through the image quality of a system, the ease of use, and the support we can bring to the customers. Of course, we have a laptop solution which is used in a clinical environment, very easy to maneuver, and which hosts all the most advanced technologies, all the Dopplers, all the probes on a 5 kilogram format, battery based. But the device you already know, I'm sure, and which is very popular in the neonatologist pediatric segment, is the U-Lite, the U-Lite Pro and T-Lite Pro, which is you see, I have it one in my hand. It's a very small device that can be used near the newborn, just next to him. And with this device, you're able to have all the probes that you will need for good care of the neonates. We also offer a training facility for our customers through actual workshop here in France, but also abroad. We were in the US a few weeks ago having a very interesting workshop with the AUM. So stay tuned because it's very possible that we're gonna hang on with a workshop near your country. Thank you very much.
Good evening, everyone, or good morning, maybe, good night. I'm really excited to be here this evening here in Paris. I know so many of you will be logging in from countries all over the world, 52 countries, maybe 53. That is just amazing. And I mean, what could be better than to talk about one of my pet topics, lung ultrasound, and ask the question, is it our new best friend as neonatologists? First of all, I need to make some disclosures. There's no conflict of interest, but we know this webinar is hosted by Sonoscanner. So what about lung ultrasound? Lung ultrasound, like other forms of point of care ultrasound, is our tool as clinicians. We use it in a targeted way. We have a specific question in mind when we do this, and we repeat the examinations at the point of care. And the most important thing I would say is whatever we find really needs to be interpreted in the clinical context. Point of care ultrasound is the extension of our clinical examination. It's an adjunct to the monitoring tools we have. It is not a standalone examination. And what about lung ultrasound? It's not really that new. It started a long time ago, and I really want to pay homage to Professor Daniel Lichtenstein, who was one of the first who really started to find a system in all these artifacts. Before that time, we thought that it was impossible to scan the lung because it's air-filled. Turns out, as most of you know, that is incorrect. We can use ultrasound in the adult, in the child, and in the newborn. And for me, these two papers are really what got me going, at least, scanning neonatal lungs. The first two papers from Kopetia and Katarossi and their teams that came out in 2007 and 2008 actually paved the way for neonatal lung ultrasound by showing that there are specific patterns to specific neonatal diseases. It actually got us to think about what if this tool could be specifically used in neonatology. The first evidence-based guidelines came out in 2012, and these are high-grade evidence guidelines for adult medicine, but there was still enough evidence at the time to recommend its use in pediatrics and neonatology. And since then, although things take time, and we're lagging a lot behind the adults, we do have our own pediatric and neonatal specific guidelines with the ESHNIC guidelines that came out in 2020. And since then, things have started to move forward. So why would you use lung ultrasound if you're not using it already? Well, first of all, it works. It has an excellent diagnostic accuracy. These are works by Daniel Lichtenstein. And you can see that for most of the diagnosis, the main diagnosis, effusion, consolidation, pneumothorax, and aspirate, it has almost the same or the same diagnostic accuracy as CT scans. And what about in children and in neonates? Well, for neonates, we're getting more and more evidence that for specific neonatal diseases, for specific neonatal uses, such as predicting the need for the first dose of surfactants in preterm infants, for predicting the progression towards BPD, pneumothorax, for example, we're starting to get enough evidence to say this is a tool particularly well adapted to our setting. And of course, let's think about the practical things. It's bedside, we have the results immediately. And most neonatal units in many countries already have a device. And of course, one main thing is that it is non-radiating. And we are actually asking ourselves about potential long-term risks of multiple exposures of radiations in preterm infants and in newborns. The babies are small, they are echogenic, they're easy to scan, and in the beginning at least, they have few comorbidities. I would say a real question is also what the added value is. Non-radiating, yes. High diagnostic accuracy, yes. But the thing is, we don't really, up until now, have a satisfactory gold standard for neonatal respiratory diseases. Most of us are using chest x-rays. I mean, we cannot use CT scans, right? It doesn't make sense. The chest x-rays are very useful, but for some indications, their diagnosis accuracy has never really been evaluated. And we know they can be difficult to interpret sometimes. Lung ultrasound has a steep learning curve as compared to, for example, echo. And coming back to the fact that it's non-irradiating, this is our personal experience. At Paris-Saclay, we introduced lung ultrasound to the unit in 2013. And a year later, it had become our first-line imaging technique. And going through our data, we found that by changing this policy, we were able to reduce the number of chest x-rays per baby by half, which meant that we were reducing the radiation by a third. And if we want to think globally, environmentally, our planet is not in good health. And being able to reduce also the waste related to x-rays could be of benefit for everyone. In addition, once you invest in a machine, once you invest in training, then you can actually come up with cost savings, which can be significant. And this has also been found in adult medicine compared to CT scans. Then what about me? Why do I do lung ultrasounds? Well, because it has changed the way I'm able to manage my patients. And I've been very lucky to have been trained by Daniel Lichtenstein and to have been mentored also by Luigi Catarossi, who have really opened my eyes to the use of lung ultrasounds. And before I go further, I also need to thank the team with whom I have worked for the past years at Paris-Saclay, Clamart Hospital, and with whom we've done many of the studies, asked many of the questions. And this is the team that is still working on trying to find answers to many of the questions that remain. And really, this is how it worked. I told you we started training the whole team in 2013. By 2014, everybody on the unit was using it. And it is, and still is, our first-line imaging technique for any baby coming in with respiratory distress. Throughout the years between 2014 and 2016, we started to ask the question about how we could use this to predict the need for surfactants. And the rest is history, really. We have now changed our clinical protocol to ultrasound-based surfactant administration. And now the time is up to think about working on POCUS algorithms. What about the delivery room, transitional period, low and middle income countries? The list is long. We have so many questions, and I'm so happy many of you are already tuned in today, because it's only together that we may be able to answer some of the questions. Very quickly going on to which machine you would need. Well, I would say if you don't have a machine, try to think about a machine you can also use for other uses. If you do have a machine, then it is the machine you need. Lung ultrasound doesn't need sophisticated post-image processing. It's really the analysis of artifacts. And which probe would you use? Again, the probe you have, but some probes work better than others. Traditionally, we're using linear, microlinear, Hockey-stick probes for the neonatal lung. Having said that, the microconvex probe is also very, very good for that. At the bottom, I would say, would be the phased array or the cardiac one, which definitely allows you to see different patterns, but it's much more difficult to analyze the pleural line. Most of the images you will see now have been taken with a linear or microlinear probe. So let's go through the basics. One main physics fact is that ultrasound beams cannot go through air. It is impossible. They just don't, which is why we use gel. What we do hope is that we have an air-filled lung. So how does this work? Well, the ultrasound beams will go as far as they come until they come to the intersection between the air and the fluids in the lung. And this will generate artifacts, dynamic artifacts that we'll be able to classify, which will give us an idea about the aeration of the lung, because the images we see on the screen, they arise as the result of the ratio of air and fluids in the lung. And being able to know these patterns will give us insights into the underlying aeration and the underlying patterns. So what are the limitations? Unfortunately, this is not magic. It would have been lovely. Well, the limitations are really simple. It is that in order to be able to see a lesion, it has to be in contact with the surface, which means that theoretically speaking, if we were to have like a large lesion, air-filled, like this balloon, it will be invisible on lung ultrasound. Having said that, for all practical purposes, almost all lesions in this acute setting are visible, or we're able to visualize them on lung ultrasound. But that just means that if the images you're seeing on the screen do not make sense with the patient's clinical picture, with the patient's clinical course, please do a complementary imaging technique. In our case, that will probably be the chest X-ray. Another thing is that we're not able to evaluate for overdistension. Once the lung is aerated, it is today, at least in the newborn, not possible to say if it's just normally aerated or whether we've gone beyond. And as for any technique, we need to be systematic. And this is, for me, especially important to underline, because lung ultrasound is a simple technique. But that doesn't mean that it is easy. It is a simple technique, and it depends upon being systematic and using a stepwise approach. If we're not systematic, if we skip through the examination, we might make mistakes, and our babies deserve better than that. So where do we start? I will be referring a lot to Daniel Lichtenstein in the coming slides. So step number one is look for the back, which means basically we need to find the lung surface. We need to find an intercostal space that is formed by two ribs with their acoustic shadowing and a brighter hyperechoic line, which is the pleura. And Daniel Lichtenstein has described this as the bat sign. I don't know if you can see my pointer, but it is the image that you get using at least a microconvex probe when you are looking at an intercostal space. Schematically, one rib with acoustic shadowing, another, and in between a brighter hyperechoic line. Anything above this line is subcutaneous tissue. Anything below that line is artifacts. This is the lung surface. And if you were to scan like here a 500-gram baby, using here a hockey stick probe in a rib short axis, so a vertical scan, this is the image you would see. And these are images taken here with a linear probe. You can see we can actually see 3 intercostal spaces. This is how easy it is to scan a baby. Or here, using a microconvex probe. We're able to see the rib shadowing, and we know this is the lung. Next step is, here, if you want to have a complementary view, you can also do a rib long axis. That means you slide between the ribs. You will no longer see the rib shadowing, and you're able to see like a dome-shaped image that gives you a larger area of the lung, like here. And we often use this in neonatology. Do you need to do both? No. You need to do one. I would definitely start with the vertical, so the rib short axis, to be sure it's the lung. And then in order to get a global overview, I would then switch to the rib long axis. And by convention, like for the cranial ultrasound, for those of you who do this is always the upper part of the screen, superior cranium. This is the lower, inferior column. And if we're doing the rib long axis, this is the right side and this is the left. Once we have found the lung, we need to check this pleural line. Is it regular? And is there this back and forth movement called lung sliding? We're not able to visualize the two leaflets of the pleura, what we see is this brighter hyperechoic line. And for me, this is the most important part of any lung ultrasound examination. It is once you found the lung, it is to see whether you have this back and forth movement of the pleural line synchronous with respiration. This is very important. It is important also that your machine settings be set. You remove the filters, remove any extra stuff, so that you're always able to identify lung sliding on your machine. And if you go back to the images I showed you earlier, you can see that we're looking at this sparkling movement, synchronous with respiration, and you can see the movement is relative to the subcutaneous tissue. Absent lung sliding is never, ever normal. Sometimes you may be a bit unsure. Then you can use the M mode. And the M mode will show you the seashore sign. Basically, it is the subcutaneous tissue is static. It will not move. It will give you these horizontal lines, whilst the moving lung will give you this fuzzy, sand, grainy type of picture. And the difference between the upper and the lower part shows you there is lung sliding. So you found the lung and you've checked the pleural line and you've assessed for lung sliding. Then you need to see what kind of artifacts you see. And you can see that it's basically based on pattern recognition. Completely white lung versus the normal looking lung we saw. It's not difficult to see the difference. The question is, what will you use it for? So in a normally air-filled lung, the ultrasound beams will go as far as they can before they reach air. Basically, that will be the pleura, right? The visceral pleura. And then they will bounce back and forth, back and forth, back and forth. And we will see the repetitions of this pleural line that we call A lines. A lines for air, or A lines for air, sorry, or A lines because it's the first letter of the alphabet. These are basically just reverberation artifacts or reflection of the pleural line. They just show you there's air. Could be normal, could be abnormal. They're just artifacts of repetition. And if we go back to our normal scans here, why do I say it's normal? It's normal because the pleural line is well defined, it is sliding, and we can see these A lines. But most of our patients have some kind of inflammation, some kind of edema in the lungs, which means that the ultrasound beams can go a bit further. And what we see on the screen are what we call B lines, B because they come after A. B lines are vertical laser beam-like artifacts that are dynamic. And the B line club is very exclusive because there are many B line wannabes. Artifacts that could look like B lines but don't have all the criteria. There are many. But the main criteria are that they always start at the pleural line. They are thick, common tail laser beam-like, as you can see here. They don't lose in intensity as they go all the way down to the bottom of the screen. They will, let me show you here, like this here. They will move with lung sliding, and if you have an A line, they will erase them. And you can have a few B lines, you can have many B lines, and it is really a reflection of the interstitial compartment. If you have, you're allowed to have up to 2 B lines per intercostal space. That's normal in your anterior and lateral chest walls. If you go above that, then you have an interstitial syndrome. And the more fluid you have, the more B lines you have. So we can have patterns like these. This is normal. Now we have many more. And we can go all the way to this completely white looking appearance where there are so many B lines, we're not able to count them. So severe interstitial syndrome. A lines for air and B lines for interstitial fluid. And then we have consolidation when the lung is no longer aerated. It just collapses, right? Filled with fluid. And it will look grayish. It will look like the tissue, like an organ of the spleen. And inside we could have these bright spots, which are bronchograms, basically trapped air. So smaller consolidations are characterized by their irregular deep borders, so the shred or the fractal sign. And in pediatrics and adult medicine, sorry about that, they don't see. You could ask whether these bronchograms are moving outwards, whether they're dynamic. You would need to rule out pneumonia, or if they're static, so no outwards movement like here, maybe atelectasis. Let me share with you that it's much more difficult in neonatology. We're able to see the consolidations like here, and you can also see that you got whitish spots here, but are they dynamic? Are they static? not always easy to see, and can we use them only the consolidations to say whether it's pneumonia or atelectasis? I do not think we should ask that much from lung ultrasound today. And then finally, what about effusion, free fluid? Well, free fluid is usually seen as a darker space, hypoechoic space. The most important thing would be to know where you are, to be able to identify the structures, know where you are in relation to your diaphragm, which is why it's also very important when you're doing a full scan, when the baby's stable enough, to do a full scan of the anterior, of the lateral, of the posterior chest wall. Also, the diaphragm you will see, not only to assess it, but to know whether what you're seeing is above or below. And depending on which probe you're using, you would see different images. But this will be usually darker, not always, sometimes can be hyperechoic. So let's talk about some pathology. What about pneumothorax? So pneumothorax is air between the pleural leaflets, and ultrasound beams cannot go through air. So what would you expect to see if there's pneumothorax? Well, we're going to use the limitations of ultrasound to make a diagnosis. First of all, we can rule out pneumothorax very easily by looking at lung sliding. If we put the probe at this area where there is air, the ultrasound beams will only be able to go as far as the parietal pleura. They will not be able to go all the way to the visceral pleura because there's air. So we will not be able to see lung sliding, which makes sense, right? But that means that if we do see lung sliding, let's say you're scanning crashing infants, a child that's not doing well, and your question is, does this baby have pneumothorax? Well, if you see lung sliding, you know for a fact that that baby does not have pneumothorax in this area you're scanning because you see lung sliding. So the signs of pneumothorax are absent lung sliding. Here's the pleural line. There is no movement of the pleura as shown before. You will have the reverberations of the parietal pleura, which will be the A lines. That means that if you see a B line, which comes from the visceral pleura, this cannot be pneumothorax. That also rules out pneumothorax. And if we're using the M mode to check, you will find what is called the stratosphere or the barcode sign, meaning that instead of seeing this pattern, you will see this pattern. Nothing is moving. All you're seeing are just horizontal lines. Is this enough to make the diagnosis? No. You need to go a bit further. You need to go laterally, because if you're scanning a patient with pneumothorax who's supine, the air will go up, right? Because lung ultrasound follows the rules of gravity. Fluid goes upwards. Air goes upwards, fluid goes downwards. So if you're scanning the anterior chest wall, you will be able to see these signs because the air will accumulate, and then you would need to move your probe laterally until you find this point of separation of the two pleural layers, and then you will find a pattern that is specific to pneumothorax. You will find what we call the lung point, which is basically on one side, you will see no lung sliding, only A lines. And at some point, you will find the area that is still sliding. Here we also have B lines. This lung point is what gives the specificity for pneumothorax, 100%. So if you see this pattern, it can only be pneumothorax, and it also gives you an idea how large the volume is. If it is confined to the anterior chest wall, not so large. If you're coming to the lateral, it becomes significant, and once you pass the posterior axillary line, then this is a large pneumothorax that you probably want to treat. So what you do if you don't find the lung point? It can be absent. Well, the recommendations say that you should do a complementary imaging technique if your patient is stable. However, if your patient is unstable, in pre-arrest, in arrest, or if you're on a low resource setting, treat as pneumothorax. And here are some images for those of you wondering whether you can see it on CPAP, on non-invasive ventilation, or even on high-frequency ventilation. You can see all the signs. And so does it work in children? Actually, we have enough data to say that the use of lung ultrasound, the diagnostic accuracy is very good. It's actually much higher than in adults and much, much higher than chest x-rays. So going through the schematic, you need to be systematic. You need to take it pointwise. Find the lung, check the pleural line, check for lung sliding. Do I have A lines? Yes. Do I have B lines? If I have B lines, do I have more than 2 per intercostal space? Then I have interstitial syndrome. If not, I move on. Do I have consolidation? Do I have effusion? Only once you're in the green, you can say that you have a normal scan. And again, whatever you will see will give you an idea of the underlying aeration. So a normal lung is 98, 99% air. You will see lung sliding and A lines. And then you have the interstitial component. You have edema. You've got the B lines that will increase, increase, increase until you get to around 80%, which is a white lung appearance. And then there's nothing in between. The lung just closes up, the alveolar collapse. And then you will see the consolidation. The only time you have 100% air in the area you're scanning is in pneumothorax. Now gets to the topic. How do we translate all this to our neonatal reality? Our questions are a bit different, right? Is it RDS? Is it TTN? Do I need to leave the baby on CPAP? Should I give surfactants? Should I transfer the baby? These are the questions we ask. What we know today is that lung ultrasound can diagnose most common respiratory diseases, and the patterns can predict the need for NICU admission, for surfactant administration, and so forth. Using this pattern, which is normal, we need to talk about the transitional period. Because what's different with neonatal lung ultrasound is that for adults and pediatric patients, they will have edema on a dry lung, right? Unless they have a chronic disease. Our babies are transitioning from a fluid-filled environment. So they have wet lungs and they're aerating the lungs. So it's going the other way. So it would be quite normal to have a wet lung or areas with B lines in the beginning. Actually, what we do know is that airway clearance starts immediately. And for most babies, this will happen within the first hours of life, although some will need up to 24 hours or more. So it goes from a consolidation before the first breath, then you've got a white lung appearance, and very quickly you start to have areas with well-defined pleural line until you clear mostly. And static compliance goes up. So basically it's a 1, 2, 3. And we know by using these patterns 1, 2, 3, we can actually predict which babies will go on to need admission to the NICU for respiratory support. Babies who have trouble clearing their lungs have a higher risk of needing CPAP or non-invasive ventilation or more later on. What about the babies who have problems, who need admission? Well, one of the main diagnoses is transient tachypnea of the newborn, basically delayed fluid resorption. What would we expect to see? We expect to see edema, right? We expect the lower areas, the dependent areas, if there are. Baby has had time to get dependent areas, be full of B lines, right? But we would expect to have areas with normal or almost normal looking lungs. And this is exactly what we see. As you can see in this baby here, you've got 4 intercostal spaces. The upper areas show, the lung shows lung sliding. We've got 2 intercostal spaces with A lines, maybe a few B lines, not many. And then we've got the 2 intercostal spaces, the lower ones, that are completely white because of B lines. When we see this clear-cut distinction, we call it the double lung point. You can't see it in 50% of the cases. It just confirms your diagnosis. But basically what you're seeing is a mix of A lines and B lines. And that makes sense because this is exactly what's happening. The babies are just needing some extra time to be able to adapt. So you could have this very short cut limit between the areas that are well aerated, or you could just have a mix. But it is a mix of A lines and B lines. So what about RDS? Well, RDS is surfactant deficiency. And this is not confined to one area. RDS is homogeneous. RDS causes increased work of breathing, increased alveolar tension, which means that the alveoli will collapse, the surface tension is too high, the baby is not able to maintain alveolar opening. And what you would expect to see is exactly what we're seeing. Both lungs are the same. We have an ill-defined thick pleural line that can be quite irregular because of the small alveolar syndrome or larger ones. We have multiple B lines, so many that we are unable to count them, what has been called in literature coalescent B lines. Like here we have 4 intercostal space, we have conserved lung sliding, and a very irregular pleural line with a white lung appearance. The lung has lost a lot of aeration. The lung is not well aerated. Sorry, it has not been able to aerate. And sometimes you can even see larger consolidations like here because of increased work of breathing. And the baby's unable to maintain opening. So RDS versus TTN. Well, RDS, you've got areas with A lines, right? Because the lung is clearing up. Whilst RDS, the lung is completely white everywhere with no spared areas. And it's quite easy to see the difference between both patterns. How can you go a bit further? I talked to you about how we could use lung ultrasound to predict the need for surfactant administration in preterm infants. Well, by using these patterns, either it's the 1, 2, 3 patterns or using a more numeric score, it is possible to give a number to the different patterns. There are many different scores out there. I will talk to you about the BRAD score because that's the one I use. It's a very simple score adapted from adult scores. Basically, you divide each lung into 3 areas, sorry, which means a total of 6 areas. So upper and lower anterior and the lateral. We scan the posterior areas, but we do not give a score. And ESTER is, because in France we use the word echography for ultrasound, it is echography guided surfactant therapy. So basically, depending on the pattern you see, normal, or a mix of A and B lines, or only B lines, or consolidation, you will give a number to each of these regions. And the total score will give you the lung ultrasound score. And if it is above 8, so 9 and above, this baby needs surfactants. The likelihood of this baby failing non-invasive ventilation is very high. I cannot give you, if I don't remember, 92, 93, 94%, depending on the studies, but it is very highly predicted. So this is an example of a score of 0. You have very nice A lines, the lung is well aerated, you're confident that this baby is able to maintain lung opening. The score of 1 is when you have a mix of A and B lines. So you have multiple B lines, 3 and more, but you still have A lines. And then you have score of 2 where the lung is completely white. You can have multiple smaller consolidations. And then the score of 3 is when you have larger consolidations above 0.5 to 1 centimeter like here. So giving this total score will give you the lung ultrasound score. And if it is 9 or above, this is how we use it to very early on decide which baby will go on to need surfactants. It is particularly good in predicting the need for surfactants in preterm infants under 32 weeks on CPAP. This randomized control study from Spain is very interesting because they divided the group into standard care, which is using the European recommendations based on FI2 limits, and the ultrasound group, which then is either the FI2 or the lung ultrasound score. And you can see the difference. Only 6%, I think, of the control group got their surfactant within the recommended 3-hour time slots. The whole ultrasound group did. And we have had actually 3 meta-analyses till now. And this is the latest one that came out in 2022. And all the studies out there show that lung ultrasound scores accurately predict the need for the first dose of surfactants. And this is very interesting to know. And this is our experience. We were not too bad before we started implementing ESTER, but we became much better afterwards. And meaning that most of our babies get their surfactants within the 3-hour time frame when we use this. So in my setting, babies come in, they're stabilized, they get their lines in to prevent hypoglycemia and hypothermia, and then within 45 minutes, 1 hour on CPAP, give them time to start their transitional phase, to adapt. We will do the full scan and score. If the baby has 9 or above for the lung ultrasound score, this baby will receive surfactants. If the baby is below, we'll just leave the baby. And it does not come at the cost of increased surfactant administration. It doesn't reduce it either. And there are studies ongoing trying to see how that will also affect progression towards BPD and other respiratory outcomes. Well, what about meconium aspiration? Quite common in some settings, rarer in others, but always a nuisance. We know there's a huge spectrum and it is can be a very severe diagnosis, and it is particularly difficult to manage and to ventilate. Chest x-rays often give you the diagnosis and you usually have the history. But what I like about lung ultrasound is not only that it gives you this 3D vision, but it actually separates. I mean, on the chest x-ray, areas are white or patchy. But on the ultrasound scan, you can see what they mean, right? You can see the areas with consolidation or atelectasis. You can see diffusion, and you can see the areas of interstitial syndrome and B lines, and you're able to see how that moves The plugs, you know, what you're expecting is exactly what you see. Meconium plugs will plug the airways, which will collapse. And then you've got the surfactants in activation and the inflammation coming in. And this mismatch, right, and this extremely heterogeneous lung. And you can follow that up on lung ultrasound, and you're able to see how your management will change, how when the meconium is dissolved, how that changes. So it's a very valuable tool, not only for the diagnosis, because that you usually have, but also and specifically for the management and ventilation, guidance, and so on. What about BPD? Can we use a lung ultrasound to predict BPD? Well, it's a very complex disease, and I'm not really sure we actually know what BPD is. But there is growing evidence that using the same scores or more extended scores, you're able to very early on be able to identify which babies will go on to have the official diagnosis of BPD and which ones will not. And it's as early as 1 week of life. And this is the latest meta-analysis showing with all the pooled studies, either using a more extended view or not, starting 1 week of life, the babies have a different trajectory, whether it be the simple or the more extended scan. Very quickly on congenital lung malformations. In my setting, most of them are diagnosed internatally, and we don't have that much data. They're rare, but they can lead to considerable mortality and morbidity. What about congenital hernia? Well, not only do we need to check the diaphragm, but it's basically finding, like here, you've got gut in the thorax, being able to follow up lung aeration, being able to check how babies are responding to treatments. And this is why I said it's very important to be able to be sure you're scanning the lung, because sometimes it could mimic the lung. So you need to be very systematic while doing this. CPAM has a very specific pattern in some forms because there are different forms. It is the only disease where you have multiple cystic structures in the lung in the newborn. And if you do see that, please think of referring somewhere where there is expertise, where there is scanning, where you can do this. And finally, before the end, we've talked about the different patterns. We've talked about the specific neonatal diagnosis. But what about integrating lung ultrasound into more global algorithms, where we're not just checking, is it RDS or TTN or is it pneumothorax? We're actually asking a specific question like the adults do, and like Daniel Lichtenstein's protocols, like the Blue protocol, the FALS, and so forth. Having a specific question, being easy to learn at the bedside that must not interfere with the ongoing management. We don't have a lot of neonatal experience, but we're starting. The first one that was published is the SAFER, so sonographic assessment of life-threatening emergencies in the NICU, using a one probe, rule in, rule out approach for the most urgent complications on the NICU. So who is this patient? Well, the patient is a previously stable patient on the NICU who goes on to severely decompensate without a clear explanation, meaning needing resuscitation or loss of oxygen to maintain SATs. And this is a flow chart where you start off by eyeballing contraction and thinking about, do I need to, and you always need to think about congenital heart disease. Focus will never rule out heart disease, congenital heart disease, sorry. First question is it tamponade? Looking for signs of tamponade, going on to try and roll in or out attention pneumothorax, and then effusion. And it crashed, I think. So I need to stop sharing and start again. Let me try and see. Sorry about that. Well, even though this has crashed and I need to restart, we have worked further on to use the SAFER approach, which is basically extending it to extra thoracic indications. So you go down and try to assess the abdominal aorta to check for signs of critical aortic occlusion. So if you have a pulsatile aorta, then you're able to move on again. So I will stop sharing. I will try to reshare now. Let us hope this works. Are we good? And
yes.
Let me see here. There we are. Ah, no, stuck again. Otherwise, it's not fun, right? I have to have some technical issues. There we go. Moving down to the abdomen to check for abundant free abdominal fluid, or you would suspect something abdominal. And in the end, moving up to assess for severe intracranial hemorrhage that you cannot treat, but where you can give supportive management. So basically tamponade, tension pneumothorax, effusion, critical aortic occlusion, free abdominal fluid, or severe IVH. And there's also the CMP protocol that also includes other organs. So to conclude, lung ultrasound is a simple technique. It needs a systematic and stepwise approach. And above all, it must always be interpreted in the clinical context. It's simple, but it needs a lot of practice, not to understand what we've been talking about today, but in order to be using it as a kind of visual stethoscope and to be able to use it in patient management. And lung ultrasound has been growing exponentially in the past years in neonatology. We've learned that we can diagnose specific neonatal diseases. It's an excellent investment in practice, really. But unfortunately, we still have limited training opportunities and above all mentoring possibilities today. What about the impact on resource limited settings? There's a lot of work that needs to be done. And of course, certification, common curriculum. I'm part of the ESNIC focus working group. I'm very privileged to be there. And we're working now on trying to let's say, come up with a unified lung ultrasound, neonatal lung ultrasound curriculum so that we all do the same thing. So I'd like to thank you all. I hope you were able to, I think I hope it was worth your time. I'm looking forward to the questions and answers. And if you have any additional questions, feel free to send me an email on this email here. And because I really believe that when you go alone, you can go really quickly, but it's only together that we can go far. And the newborns we're treating, they deserve that we give the best. So if you want to be part of a network, be it for training or for research, or just staying in contact and try to promote focus on lung ultrasound, please become part of the JEP, which is the French group of pediatric and neonatal lung ultrasound and focus. Thank you very much.
Thank you very much. Is there any question? Feel free to ask through the Q&A of the Zoom. Yes, it's already started.
I have a question. What do I do? Answer live?
Yes.
I will answer a question live. Thank you, Marcus. Is there a role for AI interpreting neonatal lung ultrasound images? Oh, I definitely think so. Lung ultrasound is about pattern recognition. And this is basically what we're doing. And AI is much better than the human eye for interpreting patterns. And there's a lot of work ongoing. The question is really, what should we be looking at? We need to feed the algorithms so that using AI, machine learning, and so forth, we have more robust models. So definitely, the quick answer is yes. I believe in AI for neonatal lung ultrasound. Any other questions?
Yes, from Prakash Manikwat.
I don't have them here. Yeah.
Lung ultrasound findings in pneumomediastinum and lung recruitment during ventilation. I don't know if it's.
I'm not seeing the questions, but thank you for your question. So what signs can you see mediastinum and how you would see it? Yes, you can. We actually often see it as when we're scanning the lung, you can see something that looks a little, it has the same patterns. Air will always give you the same pattern in the absence of lung sliding, the fact that you actually join an area where you have lung sliding, but it's really central. And if you really look at what you're looking, if you really take time to put your probe a bit more medially when you're scanning the anterior regions, you will probably often pick up some mediastinum. And the second question was, I'm sorry, because it didn't pop up on my screen. I'm sorry, if you could type it again because I missed the second one. Could lung ultrasound one day replace the stethoscope in the NICU? Marcus asks again, well, that depends what you mean by replace, right? It is a stethoscope. It is our visual stethoscope, but you still need your, the other stethoscope because it is the extension of the clinical examination. I don't believe that lung ultrasound should replace your clinical examination. I think it's the extension. So I think you need both. What do I think of the accuracy of the ETT placement confirmation via ultrasound compared to X-rays? I think it's actually really good when it comes to knowing whether or not you have intubated the patient or not. Meaning that if you're intubating a patient and the patient is breathing or, being ventilated, you will be able to check for lung sliding on both sides. If it's symmetrical, then you're ventilating both sides. There are also other signs knowing whether or not you're in the esophagus or if you're in the trachea. When it comes to knowing exactly where you are, meaning that you have the exact placement of your ET tip, it could be more tricky. It is possible. Studies show that you can find it, depending on the patient's age, 0.5 to 1 centimeters above the aortic arch, because this is where you probably have your carina, but it needs a lot more practice. So what do I think about the accuracy compared to the chest X-ray? I would say it depends on your level of experience, but it's definitely doable, and there are many signs. Ayuk Joanna is asking, Joanna, hi, nice to see you online. Wondering whether the adult convex probe could be used in the neonates. Because in the low resource areas where she's practicing, there's no access to the neonatal probe. I would say that, like, theoretically speaking, it should not really work, but I have tried it in a very low resource setting, and it did. So I think that we need to keep in touch, and you need to tell me how it works for you. I would think that you need to go for, because most probes have a range of frequencies, you would need to go as far up as you can and play around with the different settings you have on your machine and see what that gives you. And I'd be happy to take that after the webinar if you want to stay in touch and see which kind of images you're able to get. I will be happy to be part of that if you want to. Another question is, how could we use the lung ultrasound for extubation? Yeah, I also wonder about that. I think it's very interesting to do a scan before you want to extubate, but using a specific score to say yes or no, I think today is much more complicated. I would say that the decision to extubate or not, it's based on multiple factors. Depends on who your patient is, why the patient has been intubated, and so on. But definitely doing a lung scan, if you have a lung that's completely de-recruited, multiple consolidations, not really well aerated, on settings that the baby will probably have after extubation, it doesn't look that good, right? You need to open up the lung. However, if the lung is relatively well aerated on low settings, this looks more interesting. But many people, many teams are looking at this, also combining the diaphragm to see whether or not this could be interesting. I think it's a very important research question, and more than anything else, it's a very important practical question. Yannick wonders about how we keep our probes sterile and what protocol we're using in the NICU. And do I think that we should be using ultra-portable ultrasound devices in neonatology? Well, I'll start with the second question first. I think that we need to be practical. I'm not sure that the very large machines, bedsides that we have that are fantastic for echocardiography are necessary to do a lung ultrasound scan. Many of us only have access to ultra-portable ones. I think any machine, probably with a few exceptions because I don't know them all, could be used. So I would say, yes, they should be validated in neonatology because many of us, like going back to Joanna's question, many of us only have access to that. So we have to work with the equipment we have until the producers shout out to Sonoscanner here, think about our patients as being a target population where we get the equipment we need. We don't keep our probes sterile, but what we do is we sanitize everything before, meaning the probe itself all the way down, like the, what's it called? The whole thing, and also the keyboard and the screen before and after each patient. And we have in my unit like a checklist every day. It's been taken when nurses aid, like cleans the whole thing. I've also worked in other settings like the MSF setting, Doctors Without Borders, that have very good protocols on keeping probes and machines clean. And I think there is a solution in every setting. What about BPD? Is there a role in BPD monitoring? I would say yes. I talked about the scores, but I want to share how we use it really in clinical practice, more than just predicting, saying, yeah, this baby will probably get the diagnosis or not. It's how we actually manage these babies who have evolving BPD, you know, babies who need respiratory support, who become unstable, who stay on. So we do a lot of non-invasive ventilation in my setting. So we're using lung ultrasound examinations and scores to see whether or not we want to increase pressures, whether we want to position the babies, and so forth. So I definitely think that there is a role in managing evolving BPD and in monitoring BPD. How do I see lung ultrasound versus MPE as point of care, the ease of learning and training period? So MPE or TNE, depending on where you are, is much more complex than lung ultrasound. So lung ultrasound is really a simple ultrasound examination that is much easier to learn. The difficulty in learning lung ultrasound is not in being able to recognize the patterns. It is not as much as TNE, MPE, being able to use your hand-eye coordination to get good views. The main difficulty is the connection between what you see on the screen and what that means for the patient. You know, the kind of aha moment that we all get. The one you got with your like classic stethoscope or when you looked at EKG. So the learning curve is quite steep if you have mentors. If you have somebody you can ask for help or somebody who can review your images. And this is really the sore spot today, I feel. We do not have enough mentors. Many of my colleagues who've been to courses or workshops say, yeah, sure, I mean, I'm not stupid, I get this, right? But what do I do when I'm all alone? And this is really the sore spot. We need to give this opportunity to everyone, maybe through virtual mentoring. So if you have like suggestions on how we can work through this, please share them with us. What about lung ultrasound scores or lung ultrasound for hemodynamically significant PDA? Lung ultrasound is a super good tool to evaluate for interstitial edema, whatever the cause. We know from adult studies that it is very good at evaluating for extravascular lung water, just by simple pattern recognition, so scores, B scores. It would be the same for PDA. But the problem may be in some patient populations where you have the RDS picture in the beginning. The tiniest babies are usually the ones who have a higher incidence of HSPDA, right? So how would you be able to distinguish between lung water from, you know, just RDS being resolved and HSPDA, which is more or less at the same time? So that is a very good question, and it's a research question that is ongoing. Also, there is probably a difference in the way you clear up after RDS according to your gestational age. So the younger you're born, the smaller you are, the longer time you take. And there is not much information about the 22, 23 weekers, at least not in our setting, for very practical reasons. So that is a very good question. However, if you already have scanned your baby and you see the difference, so you have an increase in the number of B lines and you're going towards a severe interstitial pattern, yes, please take that into consideration. And where it is very interesting also is if you are following up children, babies with congenital heart disease with like a shunt physiology, this is definitely a very valuable tool, because you don't want to wait until you have signs of functional heart failure, right? You'll be able to see this lung becoming more and more like beeline pattern. And this is something that will be very interesting to combine with the echoes. What about specific patterns for chronic lung disease? Chronic lung disease is a very heterogeneous disease, and it's a large spectrum. So you would be able to see all the spectrum through. Some changes you will see is, I'm sorry, it also depends on what stage you are, right? It could be in the beginning that you have an interstitial pattern with consolidations. The smallest babies often have problems keeping the lungs open, right? An irregular, thick and plural line, going all the way to the more severe cases. These are children we don't have a lot about. I know other countries have BPD babies who stay at the hospital for many months, and we're waiting for data from them. Has anybody, yes, there are. So I have an anonymous attendee wondering about lung ultrasound in guiding indication for surfactant administration. And that is a current use, I would say, of lung ultrasound in many units, at least European units, where you base your surfactant administration policy also on lung ultrasound findings. And in the latest European recommendations, there is also a few lines saying that if you have the expertise, then you may use lung ultrasound to do so. Some studies have monitored the changes after surfactant therapy. You would not see immediate changes, but following the babies up, there are a number of studies having looked at that that are easily available. What about cutoff scores for switching non-invasive ventilation back to more mechanical ventilation? I would really say that depends much more on the score, because let's take my setting. We hardly have any ventilated babies because the babies who do need surfactant are extubated. Once many centers use the LISA technique, we use Insure. So we have very few babies being on mechanical ventilation for a long time. Our mean time on ventilation is quite low as compared to other settings. So I would not use only lung ultrasound with the score for switching. That would definitely be clinical judgment, multifactorial, and where the added value of lung ultrasound score comes in is to be able to individualize this, be it the surfactants, be it ventilator care, be it BPD babies, or PDA. It is really not just using a one-size-fits-all, being able to see what this specific baby needs at this specific time, and being able to use this added information about lung aeration to guide management. This question, I guess, is more for Sonoscanner. Is there any way to have a presentation of this webinar? I know it will be online on replay. If you've registered, I think it will be available.
Yes, yes, it should be available for the physician registered to the webinar.
Is there any different pattern for B lines in chronic lung disease? I would say the distribution is a bit different, but I would see it is truly a deserving candidate for lung ultrasound. And for the first time ever, we have been able to get an insight in what's going on in the lungs of babies who develop BPD. Of course, we still need studies to know what that would mean after discharge, in infancy, and later on. What would that represent? How that mean? And I know many studies are ongoing. So I truly agree that, yeah, definitely deserving candidate to be studied.
Great. well, almost 30 questions you answered in 10 minutes. I think it's
it's
a record.
I hope I managed to answer the questions in a satisfactory way. But I'm really honored that so many of you have spent the whole hour being online with us here. It's been a lot of fun. I hope for those of you who want to have the replay, you need to go on the site. And if you were able to see my email address, please stay in touch. I think, again, that there are so many questions that still need to be answered. And again, it's only by working together, I think, that we'll be able, first of all, to ask the questions, see whether what works in my setting, for example, works in other settings, and how to get there together. And there was the last question about plural ultrasound. It is exactly plural ultrasound, looking for effusions or not, but I think that we might actually not even be looking at the lungs the way we should be. I think there is a lot to learn, and I'm very excited to see where that will take us. And I'd really like to thank Sonoscanner for inviting me today. It's been fun.
Thank you very much. Thank you very much, Dr. Yousef. It was a very important webinar tonight. And thank you all from all around the world. Stay tuned for even more training material. And thank you very much. Have a good day or night, depending where you are. Thank you very much. Bye-bye. Bye.